All right, so I'm just going to hand it over to our speakers, John Carney, Erin Lynch, and Dr. Michael Moncure.
All right, thank you very much, Matthew, and welcome to this session of the Bioethics Consortium webinars that we're doing, as you mentioned. Just want to make sure that all of you know too that we will have, in addition to the recording, the slides, all of which will have embedded links in them for you to be able to retrieve later. Matthew will be sending them out to anybody who's registered via email, and then there's also information at the close of this session about how to retrieve them if you want to share them with others and they weren't able to be on today. So with that, I'm going to express my deep appreciation to both Erin Lynch and to Dr. Moncure. Also to welcome other colleagues of the center. I think Terry's joining us and probably will be helping with the Q&A towards the end of this. This is really the first part of a two-part series that we're going to be doing. The first one is for Ethics Consortium members to get a better understanding of what are crisis standards of care and how those actually integrate and intersect with public health professionals and the work of specifically the Healthcare Coalition that is managed by Erin Lynch and her colleagues at the MidAmerica Regional Council. This is kind of the tremendous amount of responsibility that they have in coordinating all of the different emergency preparedness and response mechanisms that exist in our region, and the coordination that is necessary between civic officials and healthcare professionals in making sure that we do a good job of responding to the needs that we have locally. Dr. Moncure has been working with Erin and her colleagues for a long time as well in this arena. He will also be faculty next week when we take a little bit deeper dive into the clinical intersections here for institutional folks, which is probably a good many of you that are involved in ethics committees will do it. So we're going to do an understanding of kind of what are crisis standards of care this week, along with the role of the Healthcare Coalition, and then next week, more in depth into the clinical aspects of implementing crisis standards of care in your facilities and organizations. So next slide, please. So on the disclosures and limitations, first of all, we have no conflicts of interest to report for the speakers. The presentation is intended to provide policy and ethical guidance. It is not intended to provide any legal or medical advice. The statements of the presentation presenters do not necessarily reflect the positions of the Center for Practical Bioethics, and the speakers, if they have any additional disclosures or conflicts of interest, will provide those on their own. Next slide. So those of you that are familiar with the center know that we primarily have worked in the area of advanced care planning, and we're working very diligently in that arena as well right now, but we've kind of completely changed our entire website and service orientation to focus on coronavirus in this region and also nationally. And as Matthew mentioned, we have a very deep and really broad resource pages that we've been trying to assemble, curate, and then promote. We've also got some other programming that we've been doing with daily updates to folks on ethical issues. But it really has kind of taken over the work that we focus on, hopefully being able to provide the most up-to-date and accurate services to you, those of you that are working in the field of healthcare and really on the front line. So I know on behalf of Erin and everybody else, and I know Michael kind of serves in this role himself already in the hospital setting, but we really, really deeply appreciate those of you that are out there putting your lives on the line every day for the care and support of everybody in our region, and also those of you that are doing this nationally that may be joining us. Next slide. All right, so our objectives for today are really just to improve understanding, as I mentioned, on how crisis standards of care differ from conventional and contingency, sometimes called surge, conventional, sometimes called normal. So the process, the escalation of the standards in terms of how it is that we respond to crises or emergencies, disasters, are kind of in that step process from conventional to contingency to crisis, and we're going to be spending a significant amount of time talking about crisis standards today. Also, to present the impact that this change has on the goals of treatment for individuals, especially those of you that are being affected by how it might play out for you in terms of also trying to balance that against survival goals of population health. To describe the ethical principles associated with the duty of care during these times of crisis that obviously affect how we respond to the need, and then exploring the roles of elected and public health officials and healthcare coalitions, which is really the work that Erin will be sharing with us, and how this affects their work going forward. All right, our purpose and intent of the standards of care are basically, this is general now, this is the intent of standards of care generally, is to govern practice, healthcare professional practice in the community and within the profession. Our job in our duty of care is to focus on the individual patient, which is really the intent of every healthcare professional, and to ensure that that duty is executed properly. And then also to set expectations about how patient-focused care, the health and safety and survival of individuals, is then balanced in relation to the population survival issues for health, safety, and survival of the population. And that's really the focus of the importance of knowing and understanding the difference from what we do when it's conventional, when it's contingency, and when it's crisis. So how is the standard of care generally applied in medicine? There are really basically 4 areas that really are important for us in understanding the standard of care for applying it in medicine. The first is related to quality. So standards of quality are required, and these are statements of minimum acceptable level of performance or results. So what constitutes excellent performance on one end, and the range in between in terms of the minimum. So it's the minimum to maximum levels of quality that we're expecting of professionals within their practice or the scope of practice that they have. The second area is medical or clinical practice guidelines, and those are the systematically developed statements that have existed within the professions, and making sure that practitioners in their decision-making really understand the specific clinical setting that they're in and how to perform within that setting. The third area is medical review criteria, which we use to assess the appropriateness of the kinds of decisions that are made, the services that are provided, and then the outcomes in the delivery of the healthcare itself. So that's the medical review criteria. And then the final area is in the performance measures that are specifically related to quantitative nature of the work. So you have quality in the first and then quantitative in the fourth. That deals with the estimate of how we monitor compliance with medical quality standards, the medical practice guidelines, and then the medical review criteria that we use in the process. So this kind of says, did you do the job that we were expecting to use for you to do related to the quality, the medical practice guidelines within those guidelines, and then the medical review criteria that would be expected of you. Okay, so how is it generally applied in law? And then those of you that may be concerned about the civil protections that would be afforded you as a provider in the field would also be interested not only in the practice guidelines and the practice requirements that you have, but then also how is it that if you have to make a tough decision, do other people within the healthcare system have your back, including public health officials when they declare emergency standards? So what is used primarily in law is what's called the reasonableness standard. And it really just asks the question about what would a reasonable person, a clinician, do that had the same level of licensure or requirements in terms of practice in same or similar circumstances. And this is particularly important because that obviously differs whether you're in a conventional situation, a surge kind of situation, or you're in an emergency situation in which the availability of the resources and tools that you have that we mentioned earlier are really available to you. So what are crisis standards in relation to this? What are they for? Who creates them? And how do they get enacted? All of that gets played out now in the process of how we respond as a community and as a society to a crisis, a disaster, or an emergency situation that we're in. So as I mentioned earlier, there are 3 different types of standards that are usually considered. The first is conventional, which is normal, and those are the kinds of things that you would find in everyday practice, that there would be a certain level of minimum that would be expected, and a pretty high level of excellence that would be expected, because it's really about, you know, everything that we have available to us in our toolkit would be applied. In contingency situations, in surge situations, those resources may be more limited in terms of what we can do. And so the expectations related to what your duty is to that patient in front of you changes in relation, not in terms of your commitment to that individual, but what resources you have to draw on to make a difference for that individual. And that becomes even more scarce and more difficult when you hit a crisis situation, through an emergency and disaster. You're going to find that there may be even more limited resources available to you. And so the decision that you have to serve that person in front of you becomes dictated by larger considerations related to public survival and public health issues. So the difference between the patient-centered and population-centered commitments, I think, are really important for us to distinguish here. The patient-centeredness of the individual clinician is always primary for that individual, for that practitioner. An escalating crisis, however, requires other folks, including us, to rebalance how it is that we respond to the personal in relation to how we respond to the population. And that decision is really, in many cases, in most cases, taken out of the hands of the individual practitioner and rests with public health. It rests with that need that we have to rely on other people who know about what's going on in a bigger picture, what's available to us in terms of being able to have everything available to us that we would otherwise have in a conventional situation. So the duty of care focuses on the greatest number. So what we're trying to do, we shift from, in a public health view, we shift from the individual being the single most important consideration to a population approach, which is basically this more utilitarian, the greatest good for the greatest number. So as the center has been working along with all of you in this field, we really have been relying on the kind of the public health declarations that are made in terms of how we follow. So right now, we just finished work with the Missouri Hospital Association on developing a framework for the managing the 2020 COVID-19 pandemic response. That publication was just released, I think, last week about this time. And as available to you, we have a link, I think, embedded in the slide itself, so that that will be available to you if you want to take a look at it. This is a framework document. It does not specifically go into the actual clinical considerations, but it is a pretty comprehensive view of what is important for us to understand in terms of how it is that we as institutions and providers need to respond to the framework that we have around us and the implementation of these changing standards of care that we talked about. The second document on the right is on the Kansas side. That document was originally drafted in 2008, 2009. The center was also involved in helping complete that during H1N1. It has since been updated, I believe, in 2012 and then again in 2013, and is now available on the KDHE website. That resource is far more intricate and detailed in terms of the actual practice and guidance that the state provides in responding to the changing clinical standards that we're facing when it gets to crisis management. So, and that also, there's an embedded link there that is available to all of you if you want to take a deeper dive into that. And I'm not going to spend a lot of time on it today because we've got a lot of ground to cover with Erin and Dr. Moncure. So so you know that these documents exist. They provide a framework and a background in terms of how public health are involved in helping us establish what it is that our job is in terms of responding to this crisis at a institutional level or at a individual level, treating an individual patient. So at the institutional level, obviously most of you are probably also right now dealing with your leaders within your institution in developing your own crisis standards of care. We've been involved in sharing a number of documents, including the one I think that many of you should have received the White Halpern model from the University of Pittsburgh, which we've shared. And since then, the state of Missouri adoption for BJC in St. Louis has also shared an updated version of that document, which I think also is being shared at KU Med, and they are also doing it. So we kind of have leadership in the acute care setting on the Missouri side and on the Kansas side, and we're sharing those documents. And Ryan Friederhert, who will be talking about that next week, along with Terry, Dr. Moncure, and Matthew, will present how it is that those institutional policies are being addressed in terms of implementing the crisis standards of care. All right, the impact then is that hospitals and physicians need to balance those individual needs versus the needs of the larger community, as I mentioned earlier. And the decision to not institute aggressive treatment may be actually operational at that time, but depending on the availability of resources that exist within the institution, which would then provide guidance and also justification for the withholding or withdrawal of treatment in some situations for individuals who have been determined either too high risk in terms of the benefit that would come to them should they receive certain kinds of treatment. So it's a kind of a triaging process that will also be explained more in detail next week. That obviously poses challenges for families and residents of nursing homes in terms of understanding those limitations. It's important for us to be as transparent as possible, and that's why these documents exist and are shared as we can, as publicly as possible. So in a minute, I'm going to turn this over to Erin and have her kind of pick up the role of the healthcare coalitions. I just wanted to make sure that you all understand that this important role that the healthcare coalitions play really find their basis in these documents that I've already cited. In the Missouri document, as I mentioned earlier, it's on page 9, and it talks about the important role of the regional healthcare coalitions in making sure that guidance and support is provided to all of us at the institutional level. The same is true on the Kansas document, where it says that the regional networks play a vital role in assuming that modified triage protocols are implemented. So this is a very coordinated public health effort and really comes to bear for you at the institutional level and with the patient in front of you. So there's a lot of complex coordination that goes on here. And again, I am deeply appreciative to Erin and all of her colleagues have been at this for a long, long time. And I turn it over to her now and ask her to kind of share with you a little bit more about the important work they're doing across this region and across many, many different providers in making sure that we have the best resources available to us. So thank you very much, Erin, for joining us.
Thank you very much for the invitation. And I'm really part of a team. Dr. Moncure is he is our clinical advisor for our regional healthcare coalition. And so we're really doing this in partnership. And I think in both of the documents that Dr. Carney referenced, that it's an acknowledgement for those who may not be aware that there are things called healthcare coalitions, and that there is work being done on the preparedness side, and then when events occur, being able to mobilize that network. And that's what I'm going to talk a little bit about this afternoon, along with Dr. Moncure. Next slide. So really, the mission of healthcare coalitions is to prepare and coordinate health and medical response and recovery to the threats and hazards the region faces, to help communities during emergencies receive the care they need, decrease deaths, injuries, and illnesses. So our whole goal is to work together ahead of time to be as strong as possible in order to withstand what we're going to face when disaster strikes. And from a healthcare coalition standpoint, it's through communicating, sharing information, and coordinating resources across disciplines and across jurisdictional boundaries. Next slide. So just to give you an idea for the MidAmerica Regional Council Healthcare Coalition, It covers a large area. It covers those of you who may be familiar with the MARC 9-county area, bi-state area, as well as 8 additional counties. So in the MARC area itself, it's about 2 million people, and you can see sort of the framework for the Healthcare Coalition. Next slide. Just to give you an idea of the framework that is in place pre-disaster, if you look at our Healthcare Coalition and you look, first and foremost, you'll see a public health subcommittee. We have an active public health subcommittee that's been in place for 20-some years. In addition, so those are really your emergency preparedness public health people. It is chaired by Nancy Cowles with Johnson County Public Health and Bridget Schaefer with Jackson County Public Health, who is the director. In addition, on the left-hand side, you'll see MOHACA. MOHACA is the Metropolitan Organization of Healthcare Officials, all of the public health directors. They come together every other month to discuss a broad range of issues. And they have been working nonstop since COVID-19 first sort of sprang up. So public health is connected and working amongst themselves. Additionally, the hospital subcommittee, and many of you on this call are from facilities, and each of your facilities have someone who is responsible for emergency preparedness. Here in the region, our emergency preparedness officials from hospitals get together on a regular basis. The leadership gets together every month, and on alternating months, the hospitals themselves come together. About 30 hospitals are coming together to coordinate on their planning, their training, and exercise before an event occurs. Additionally, going down, you have what's called MARC, Emergency Rescue Committee. That is our pre-hospital care, so our EMS community, both private and public EMS. They too come together on a monthly basis in order to work together and focus on how to provide the best possible care in the pre-hospital care environment. Moving down, you'll see the Metropolitan Emergency Managers. There are emergency managers in every jurisdiction. They come together on a monthly basis. And they're looking from an all hazards approach. They're always looking at the weather and what's the weather gonna do, and how are we prepared for tornadoes? How do we provide the resources? In this public health emergency, they're really critical for helping to support resource identification and then trying to find those resources, as well as providing situational awareness. Moving down the list, you'll see KCR Morgue. We're very, very fortunate in this area that we have medical examiners and coroners and others working together to be able to, as quickly as possible, mobilize to meet the needs that will be created in a mass fatality event. In addition to working individually, the leadership of these groups come together every other month to work across disciplines to look at how can we coordinate information exchange, how can we synchronize our planning. They are the core that makes up the Healthcare Coalition. They have leadership representation from Community Disaster Resiliency Network, which is a network of organizations that serve vulnerable populations that are trying to increase their internal preparedness and also get to know their colleagues to be able to help each other. The local home health and hospice through the Kansas City Regional Home Care Association is part of the HCC leadership. And then about a year ago, standing up a long-term care subcommittee to provide a forum for long-term care who is interested in emergency preparedness to come together prior to an event to build the relationships to be able to learn from each other and be able to help one another. All of what I'm talking about is really in preparedness. So since the COVID incident has come to be, we first started talking about this as a region back in January, where there was a briefing from a public health official at our strategic planning meeting. The Healthcare Coalition continued to monitor that situation and has really ramped up, and towards the end of February, actually activated their online information exchange system to start to become a repository to see how is this affecting our area. And then they actually got together and did a threat assessment call at the same time that Johnson County was announcing their first case. So again, that's a little bit about the construct of the Healthcare Coalition. And the whole goal of the Healthcare Coalition is to do everything possible, working cooperatively in advance, to never need to get to the point of having crisis standards of care. Unfortunately, we can never say never, so we need to be prepared should that eventuality occur. Next slide. Again, these are the cross-discipline objectives of our Healthcare Coalition. It's really to increase that pre-planning and coordination, to build the strength and strengthen relationships and information systems prior to an incident, to conduct needs assessments, identify and address gaps, and always work together to try and minimize those gaps, to develop some protocols for resource allocation and mobilization, and assist in patient tracking and reunification during certain incidents, and then conducting training and exercise. Next slide. So on the response side, there is a preparedness plan and there's a response plan, and no one really sort of pays attention to those plans until events like these occur. I don't know if you read, but in the Kansas City Star, once COVID-19 sort of has affected our region, there was a tremendous amount of interest in the planning that is in place, and at the local level as well as at the regional level. But in a nutshell, our response process is any of our healthcare partners can identify a significant health and medical incident. They notify a team of 4 duty officers. They hear the information. They basically mobilize that leadership team. We get on a conference call, listen to what's going on. And from what we learn, a collaborative decision is made either to do nothing, continue monitoring, or to activate our healthcare coordination system and implement our plan. So that was really done in earnest in late February. Next slide. So one of the things living in the bi-state area that is always a challenge is just creating a regional common operating picture. And our effort to do that, hopefully this will pull up. This is sort of the regional view of the number of cases, the number being tested, the number of deaths that has been growing each day. And you can see here just sort of a regional snapshot with, if Matthew goes up, you may be able to pull up this filter. I don't know if it'll work. Go to the, yeah. Go to the first one. Over to the left. Sorry, up right there. Can you click on that? It will let you know, sorry. Darker, these are done, white are fewer cases and the dark red are more. So at a glance, you can kind of see what the thresholds are for the colors. And then over to the right, you can see by county, the number of cases. You can see the number of deaths, and you can see the source that we're taking this from. All of this information right now is publicly available information. We're just pulling it together in one area to get an appreciation for what is the impact today. Additionally, we have been using, and if you go to state projections down below, one is we want to know where are we today, and then as a healthcare coalition, we're always trying to answer the question, what do we need to be prepared for? So we have been relying on the IHME model to help us sort of appreciate what that may look like. And there are any number of models out there, and the best strategy is to use multiple models and try to see where the commonalities are. So I would caution just any models, but because these are publicly available, if you look at Missouri, there are a couple of important things I want you to sort of keep in mind. If you can, Matthew, click down on this arrow, the arrow on the, yeah, exactly. And then scroll up. This model is based on social distancing measures being in place till the end of May. And currently that's not the situation. So yeah, so keep scrolling up. Scroll up just a bit more. I think it's on here. Yes, government mandated social distancing. And so I think that we're using this information as data, but then we're needing to extrapolate from it. And this is a statewide view. So you can click on Kansas. And then what we do is we look at what does it say in Kansas? What does it say in Missouri? How do we bring that together for a bi-state view? And you know, what it really tells us is how important social distancing is and continuing that to slow the spread. If we are able to do that, then we are tremendously hopeful that our healthcare systems will be able to manage what they're going to continue to face. We recognize now that there are challenges, but right now, in listening to our hospitals, the hospitals are telling us that, yes, there are significant challenges around personal protective equipment, but also, you know, that the census is down, and through all of the contingency work they've already done, they are able to handle what they have been faced with so far. And Dr. Moncure, please step in at any time. Again, this just gives us a good situational awareness across the region. Next slide.
Wait, before you leave there, Erin, I want to have you highlight the dynamic elements of these two, well, the Kansas and Missouri ones, because I think that it allows us to say, you know, everybody keeps wondering when is the peak coming, and it actually does a pretty good job of identifying in a dynamic way. So it was, you know, a week ago, I think it was the 20th or the 26th. Right. Now it's already moved back to the 29th. So this idea that we're on the downhill slope, that, you know, that is not necessarily true as you guys collect this information on an ongoing basis all the time. So this particular tool could be very useful for people who are trying to say, well, it's time to get back to work. It's time to go, and to take a look at this and say, wait a minute, these assumptions we've made about social distancing and that kind of stuff need to stay in place because we've not even hit our peak yet. So I think it is in Kansas on the 29th. I think it may be in the 30th or so in Missouri, but Matthew's got that highlighted there. So I just think it's a really useful tool to help people understand at the institutional level how important this dynamic back and forth in terms of collection of this information ongoing is really important in making good decisions.
Yeah, and I would completely agree. This is Michael Moncure. One of the things that's pointed out in this model, you know, you can see that Kansas has a projection of by August, a little over 500 deaths, whereas Missouri has about 1,700 deaths. I'm originally from the state of California, and the projection for California deaths by August is also 1,700. So that just tells you that our actions from a public health and a civic level really affect lives. And the fact that the governor of California stepped in extremely early and issued stay-at-home orders that were statewide and were fairly aggressive has really curbed the number of deaths in a more population-dense state than the one we live in.
Good point. Thank you.
And again, you know, there are all sorts of models out there and they'll tell you different things. So that is part of the acknowledged limitation, but it is helpful to have something as a basis to think about what as a healthcare community we need to be anticipating.
Yeah, and kind of to echo Dr. Moncure's point, in the MHA document that we provided earlier, and when the slides that I clicked on, there is a section in there that has a static picture of what is going to happen over the course of the next few months in Missouri. And it's much grimmer based on the fact that the assumption was that we would have a difficulty getting people to kind of respond that in using social distancing, but it's a 40% infection rate versus, you know, the more modest one. So I would, even though that's there, and I think it's important to view, I think your point, Erin, that you just made is that, you know, looking at a dynamic document that's kind of tracking where we are right now is probably a better way. So I think, you know, prepare for the worst is certainly in the MHA document, but this one might give us a little bit better picture of how to make sure that we reinforce the need for us to continue to follow the public health guidance.
And we just got a question that's just asking, how are we able to access this resource? So we can distribute these slides to the attendees after, and anyone else who follows up after who needs them. Are there other ways to access these resources that we should mention here?
Yes, on the www Prepare Metro KC website is the link to this hub lives there. So
The Prepare Metro?
Prepare Metro KC website.
Is it
.org.
I think one of the things that has been striking, I've been on this committee since summer, and there's been a lot of action, a lot of preparation, and a lot of work, a lot of communication that even occurred prior to this incident of COVID-19. COVID-19 is a good test to the system, but as Erin very adeptly illustrated, that there's communication of all the stakeholders that are necessary to make sure that we have, as healthcare providers, people on the front line, that things work in the background, such as policy that will help us if these were to occur, but more importantly, to prevent them, such as making sure that there are caches of PPE, there are ventilators, whatever we can access from the federal government, that long-term care and acute care and EMS and emergency management individuals are sitting down, talking about all the different potential pitfalls that could occur, anticipating those and preparing for the worst. It is extremely impressive to me in talking to, we did get a little bit of a delay as far as when this COVID kind of struck us as opposed to the coast, but that time is not wasted by this coalition and Erin and her leadership from the standpoint of, again, making sure that we're prepared. When I talk to my colleagues on the East Coast and West Coast, it is night and day in regards to what is actually on the ground, who's talking, who's preparing. And one of the things that's very clear in the document, and obviously that's going to be more in depth next week that will be discussed, is that you cannot wait until a crisis occurs and expect to then put together triage committees and groups to do things, and then all of a sudden come up with a mechanism to declare a crisis. It's got to be done before, and it's during the actual event, early in the event, that has occurred, and that's what's been going on.
Next slide. Next. So in addition, for us to get our regional common operating picture, one of the things that all of the hospitals are doing across the area is they are reporting to through EM Resource, which is an online system that EMS has been using and hospitals have been using for years. And they are reporting information that then gets rolled up in a regional view. So this lets us know how many COVID-19 hospital admissions in this geographic area. And this is the bi-state picture. It also includes our friends from Douglas County. But you can see what the ventilator availability is. You can see what the PPE critical shortage, and it's because we're always trying to understand not only where are we today, but where are our risks and where might we be. One of the things the Healthcare Coalition has been trying really hard to do for the last month or so is understand the personal protective equipment needs, which have been just significant. Over 288 requests were processed through our Healthcare Coalition just on the Missouri side from hospitals, long-term care, everyone trying to make their needs known to the state. It became apparent that in spite of all of the state's best efforts and federal efforts, there's just not adequate resources, and we're not getting them quickly enough. One of the things the Healthcare Coalition has done is they queried all of their partners to identify any potential vendors and vendors, and then have shared that information across their network, hoping that those that do have the ability to procure can at least have some leads to do that. What we've heard is some of our long-term care providers and home health and others have an even more difficult time than hospitals if they're not regularly buying personal protective equipment. We also last week worked on an invitation to bid that closes on Friday, and we're exploring a cooperative purchasing. Again, just trying to break down any barriers for agencies to get them access to PPE. One of the things we've heard is there may be a supplier, but the threshold that needs to be met in order to buy from them is so high, it prevents agencies from buying. So again, a cooperative purchase could help make the needs, meet those needs. We're not overly optimistic. This is hard work. We don't know what will come of it, but as a healthcare coalition, feel like it's critically important to exploit any possible avenue. So there's been a lot of work underway from a lot of different agencies to move in that direction. Next slide. That's it. So that really hopefully gives you an understanding that there is a network of providers that are connected. We're always looking for inviting others in. And one of the things I really appreciate about the invitation to be on this webinar today is to listen to the challenges that you have, the questions you have, and then to be able to take that back to the Healthcare Coalition and look for strategies to make the situation less bad.
Thank you, Erin. I want to give Dr. Moncure some opportunity here to kind of connect to this presentation with kind of the questions and issues that may also be addressed next week as we actually look at implementation on the institutional side and in the region. So if you kind of talk about maybe more of the clinical considerations that need to go, and then we'll try to get to some questions here in the last 10 minutes or so. So your reflections on that.
Again, this is a process that you've gotten a glimpse of. There's a lot of work that's going on behind the scenes. Healthcare Coalition is doing a great job from the standpoint of trying to anticipate these needs and the ability or the possibility of a crisis situation. Again, the whole goal is to avoid that. You could see that screenshot that was done, that last slide, I think is a really good reflection of how dynamically the coalition is actually looking at, what the resources look like on a daily basis. And the hospitals have been doing a good job as far as sharing those resources. From the standpoint, a lot of you work in hospitals, and so you know that a lot of the day-to-day operations that have occurred in the past are on hold, such as elective surgery. I'm a surgeon, a trauma surgeon. I mean, trauma surgery patients come, but we've actually adopted a lot of the things that a lot of national organizations have put forth as far as trying to preserve PPE, not operating electively, and even not operating whenever possible on even urgent cases and doing medical management. But again, it's switching from actually looking at an individual patient and my individual patient and looking at the greater good. And the greater good is for us to preserve the resources such that if we do get into a crisis situation, we can manage that. Now, one of the things that happened early on is that I run a clerkship for the surgery medical students, and that was stopped. They were not allowed to come into the hospital because, again, with the thought early on that PPE would be consumed by doing that. By not doing elective operations and such, you're not putting people on ventilators that then also take that resources away from someone that could potentially need it during a crisis situation. Switching to a crisis is not to be taken lightly, but I can tell you, again, by looking at this snapshot, and that's done on a daily basis, and as Erin mentioned, that we do have on EM resources, what hospitals' ability to treat patients on a daily basis or a bi-daily basis, twice a day, is reported. And that's, again, a dynamic process, or someone's not able to take in any more COVID patients. And that could be influenced by not only just because I'm there at the hospital level, the hospital beds, could be on the number of ventilators that are available, could be on the number of staff. If your staff gets sick, and I've talked to a number of my friends on the coast that have encountered that, such that decreases your ability to take on more patients. If you've tapped out resources in any of those different areas, that's going to affect your ability to safely treat patients with COVID. So that's not taken lightly. If we're looking at that in a dynamic manner, then when we start to see these signs rear their heads, then we can start to alert individuals that we may need to go to look at this from a crisis standard. And one of the things that I've been trying to keep my eye on is that I've had a lot of opportunity to meet a lot of my colleagues, both on the Kansas and the Missouri side, as far as working in rural areas. And so having resources within the urban core, so that there could be transfers, or also Erin and the group is also trying to make sure that education is provided and resources so that patients can be treated out there as well. But
so, Dr. Moncure, can you tell us a little bit about if we are able to keep from having to implement crisis standards in most of the institutions in the region, since we've got good sharing and good coordination, is there the work that you do? How soon would we see the ability to have those surgeries that have been suspended, basically start again? I mean, people like me, someday I'm going to have to do my, carpal tunnel surgery. That can wait for months. Other people face more dire kinds of consequences related to possibly biopsies or tumor extractions and things like that need to be addressed now. How soon does that happen in relation to saying we're not at peak, we're not at crisis standards, but we're still at surge? When does that decision get made in the process of deciding when you get to, say, you would get to go back to work on some of the folks that we are very concerned about making sure they get surgery on a timely basis?
That's an excellent question. And I would say that we're looking at it on a daily or weekly basis. Right now, with the stay-at-home orders that are in place, particularly for our region, and that's been performed again and extended on the Kansas side. there's definitely no thought that that would occur prior to that. And then after that, it's going to be probably when the curve really starts to decline, and we're starting to see, a lot less cases, and so we're not seeing the taxing of our hospital resources as a result of COVID. And so that's going to be dynamic. And I think that regional picture would also give, I think, individual hospitals an indication, because it would make no sense just because I have only 10 cases at Truman, but they have 100 at KU, and there are thousands within the region. It's going to hit, because those institutions are going to actually probably have to not be able to take in more new patients, and so other individual hospitals are going to have to take that up. But I think
that dynamic picture of how well we respond to the requirements that we continue to comply with social distancing and those kind of things, that these images that Erin shared and that you shared are really going to be able to allow us to see the waves that happen as a result of we're not paying attention, we're getting a little bit too loose on how we respond, that we'll be able to use these tools and resources to indicate to us that, wait a minute, we need to be more strict in our adherence to those things, despite the fact that we all want to get back to work, obviously.
Absolutely. And I would also say that, from an operative standpoint, one of the things that has been extremely telling in reading the stories and reading articles and manuscripts from other institutions that are in crisis at this point, is that even though I want to do an elective operation, if I do that, and the time in which our healthcare, my other colleagues are at risk are during intubation. So there have been cases where there have been OR nurses or surgeons, anesthesiologists, such that have gotten sick because we've elected to do some kind of elective procedure. And there's also been initial reports out of China that it's about a 20% mortality, that even though a person is positive and they're not sick, if you were to perform an elective operation, they have a 20% mortality. So they get sick after the operation. So there are lots of things that really come into play. So, and we're testing all of our patients, even for urgent and cancer operations, prior, because it just would not be safe to proceed if someone has an active, ongoing COVID infection. So
that actually links into a question we just got from Patricia that is saying that Children's Mercy is testing patients prior to going to the OR and is asking if that's consistent with other facilities, and will that continue most likely into the summer?
I would say that would definitely be the case at my institution, and it should be at most or all institutions, because again, it's not only hurting that particular patient, but it's also putting at risk the individuals that are caring for that patient within that operating room and outside of the operating room. So the cases that have happened to healthcare workers are usually because of lack of awareness, or you've gotten a test and the test was negative, you proceed with an operation, and then the patient has gone into rampant respiratory failure after. So it's not lost upon me that even though the test is negative, we still should proceed with the minimum amount of, or the safest amount of PPE during that case to, again, prevent inadvertent spread. So in that environment, in an environment where we don't know as much as we really would like to know about COVID, I think it's best to proceed safely. And that piggybacks to John's question, is when is it safe to go ahead and proceed with elective operations? I'm struck by the fact that each week we learn more and more about this virus and it's the care of patients with the virus and its implications. So the later the better, probably.
Matthew, we're kind of eating into your Q&A time, so how are we doing here?
Yeah, we've got a couple minutes left, and if people want to submit questions via the Q&A or the chat function, I'm taking a look at those. We have one here from Monica that says, how do we convince other healthcare providers of the importance of adhering to these restrictive standards?
I think that's a hard one, because just like you can see throughout the country, there are civic leaders that get it and civic leaders that don't get it, or that have different goals. You know, I would imagine there are some of my colleagues, there are surgeons that are looking at the decrease in income, the decrease in operations and everything, and they're kind of panicking and thinking about that. But again, I think what John did initially when we talked about crisis standards is that we cannot look at individuals. We have to look at the greater good. And the greater good is that we try to ramp this down, get to a point where we can actually establish good public health standards so we can isolate the virus and make sure that our world becomes safe again. It's probably never going to be the same as it was prior to this, because we have never seen anything like this at all.
Yeah, I'd also like to do a shout out to the civic leadership in this region. I was incredibly impressed with how everybody came together at the very beginning of this. And I know there may be different times where we're looking at, you know, getting people back to work, that may be a different consideration if it's statewide or regional. But I think that the civic leadership and the public health people, everybody standing together, has really helped this region in terms of our ability to respond to this crisis. And I hope that continues, and that we all listen to the public health officials and the civic leaders. It is absolutely essential for this to be successful.
And I would just say, from a public health standpoint, the whatever we can do to increase public health capacity by providing them resources. They need more testing resources, they need more materials, they need more staff to be able to deal with the demand. So that's part of the consideration is, you know, relaxing standards. There are a number of variables to be thinking about, and that's a really, really important one.
I would say that because there's a good partnership between the Healthcare Coalition, hospitals, the MHA, and I can tell you that I've known Lee Norman for a long time, and he is phenomenal. And I have no lack of confidence of what will happen on the Kansas side. Hopefully the leadership from that standpoint will help to filter down to us hard-headed, you know, surgeons that might want to go against what is occurring.
Matthew, you want to punt this last question to next week, maybe?
Yeah, I think maybe we have a couple of questions, but we've come up against our time. And so in respect for our speakers' time and our attendees as well, I'm going to have to call it here. I appreciate all of the engagement and would encourage anyone who had burning questions to hold them until next week. We'll be convening a subset of this group next week for another webinar next time about implementation of crisis standards and what that might look like. So if this is an issue that is important to you, we'd love to see you on then as well. And I guess before signing off, I'd just like to remind everyone that these are recorded, and we are able to post them on our YouTube channel, and you'll be able to find them there and share them with anyone who wasn't able to tune in for the live show. And we hope to see you next time. I want to thank all of our panelists, and thanks for everyone's continued work in these trying times.
Thank you, Matthew. Thank you, Erin. Thank you, Dr. Michael. We look forward to having you again next week. And please, everybody be safe and stay well.
Thank you very much.
Thank you.